Let's talk about traumatic brain injury. You're on call and a patient with traumatic brain injury is scheduled to go to the OR. What is TBI and what can you do to improve the patient's outcome? Hi, I'm Dr. Pawlowski at the University of Nebraska Medical Center. Let's talk about management of traumatic brain injury, which is topic 2D9B in the ABA content outline. Traumatic brain injury is a leading cause of death and disability in the U.S. Patients with TBI often have other injuries and pathologies, such as hemorrhage, blunt trauma, spine injury, and ARDS that make management difficult. To manage TBI, we'll start with assessing and stabilizing the patient. When your patient presents, remember the ABCs of advanced trauma life support: airway, breathing, and circulation. Ensure the cervical spine is immobilized. For airway, assess how well the patient is protecting his airway and the likelihood for the airway to become compromised. Intubate the patient if necessary. For breathing, listen for bilateral breath sounds, and if the patient is on controlled ventilation, optimize the oxygen delivery and ventilation with the ventilator. You're initially targeting normal oxygen and carbon dioxide levels. Regarding circulation, maintain cerebral perfusion pressure by treating hypotension with pressors or volume resuscitation, depending on your patient. Continuing your primary survey, D is for disability. Do a neuro exam and recall the points of the Glasgow Coma Scale. 6 points for motor response, 5 points for verbal response, 4 points for eye opening. For patients who score less than 8, this is one but not the only indication for intubation. About 50% of patients with this presentation do not wake up. Often patients will present with only modest neurologic changes. They may deteriorate suddenly due to cerebral edema or delayed hematoma. Following this primary survey, most patients will need a CT scan to evaluate the type of injury. The CT scan may show depressed skull fractures, cerebral edema, or bleeding, all of which may need emergent operative intervention. Now that we've discussed assessing and stabilizing the patient, let's talk about secondary brain injury. Secondary brain injury is further brain injury that occurs as a result of hypotension, hypoxia, hypocarbia, hypercarbia, fever, hypoglycemia, hyperglycemia, or intracranial pressure. As the anesthesiologist, you can prevent this secondary injury. Your goals during the anesthetic are to optimize cerebral perfusion pressure and to control intracranial pressure. Keep the CPP above 70 millimeters mercury. Avoid hypotonic crystalloid solutions because they can lead to cerebral edema. We'll talk about choice of fluids in another lecture. Avoid glucose-containing solutions unless specifically treating hypoglycemia. As a hematoma is evacuated, expect profound changes in blood pressure and be prepared to aggressively manage hypotension. Hyperventilation should be used only as an acute temporizing measure to control ICP. When inducing a patient with traumatic brain injury, take into account that they may have a difficult airway due to facial, airway, or cervical spine trauma. Beware other non-neurologic injuries that may affect the patient's physiology, such as pneumothorax or abdominal pelvic trauma. So which anesthetic is the way to go? Most anesthetics require IV drug infusions and/or low-dose volatile anesthetics for maintenance. Plan on an arterial line if time and conditions allow. Low-dose sevoflurane is a popular choice for maintenance because it has minimal effect on cerebral autoregulation. Never use nitrous oxide for these cases. Pneumocephalus can develop, and other spaces into which nitrous can diffuse will increase and potentially become catastrophic. For brain swelling, remember what you can do to control intracranial pressure: supporting venous return out of the head, controlling arterial oxygen and CO2 partial pressures, and managing arterial blood pressure. You'll recall these principles in our discussion on the Monroe-Kelly doctrine. Discuss with the surgical and critical care teams whether continuous ICP monitoring is useful in the intra or post-operative periods. Let's review. When a patient presents with TBI, they need to be assessed, including a neurologic assessment, and stabilized. Use the Glasgow Coma Scale to quickly communicate their level of disability. Once they're stable, your job is to prevent secondary injury by managing their cerebral perfusion pressure, which is MAP minus ICP. Thanks for joining me. to learn about anesthetic management in TBI. I'm Joe Pawlowski from UNMC.